On this program, we will focus on access, defined as the cost, both monetary and time, an individual incurs when visiting a healthcare facility, looking at it from the time the country became independent. I'm your host, Constance Mwezi, and I am joined by Brigadier General Dr. Lawson Simapuka, the Dean of Medicine from Texila University.
First and foremost, I would just love to indicate that cost of healthcare is indeed very difficult to measure.
Mm-hmm.
And that's the reason that in most countries, healthcare delivery is borne by the government.
Mm-hmm.
The government through different modes, like health insurance,
mm-hmm.
which we have introduced in this country. Otherwise, the cost of health at an individual level is quite colossal.
Yes.
And I cannot really define the cost of health per se because there are different parameters.
Mm-hmm.
It depends on what you're trying to access.
Okay.
Are you just accessing an outpatient facility with only a clinical visit? Or indeed, that visit quantifies also the component of being investigated from a laboratory level, investigated from an imaging point of view.
Mm-hmm.
So it's very difficult to quantify health
mm-hmm.
at an individual level. I think let's look at it from a different angle.
Okay.
If you look at the number of health outlets at country level,
mm-hmm.
if you remember very well, in the 70s, 80s, we only had district hospitals,
okay.
and then provincial hospitals, and of course the UTH, which was the only referral hospital.
Mm-hmm.
Then, at a lower level, in the rural area, there were health posts. And if my memory is correct, countrywide, we could have had about maybe about 107 health posts.
Okay.
And that's why this time around, I think you've heard statements from the minister. They were talking of a 7-year plan to come up with 650 health posts, so that the gap to access is narrowed. So, getting back to your question, when you look at rural areas, access to health in rural areas is quite difficult.
Yes.
Especially if you're talking about access to a first level facility,
mm-hmm.
which is the district hospital.
Hospital, okay.
In that case, you find that there's some individuals that will have to move maybe for 200 kilometers or so to access a first level facility. But in terms of accessing health posts, of course, rural areas have health posts that are scattered maybe within 5 kilometers from where the village could be,
mm-hmm.
or indeed the community would be residing.
Mm-hmm.
So what am I saying? In rural areas, access to health is indeed a challenge.
Okay.
Okay, so when we talk about access, we'll be looking at maybe at 3 areas.
Okay.
We'll look at maybe the structure,
mm-hmm.
and then whether that structure is functional, and then in that structure, what could be the gray areas. So, if we are to have access to health, one, we need to put our facilities as near to the people as possible in terms of health posts.
Okay.
And then those health posts should be manned by health personnel. At the level of the health post, we are talking about maybe clinical officers
okay.
or nurses.
Mm-hmm.
supported by maybe environmental health personnel. Then access does not only include structures and human resource, but we're also talking about commodities.
Mm-hmm.
Are the individuals able to access the commodities easily? Now, how do you make this possible? This can only be made possible, one, by having an increased number of training facilities. You are aware that in the past, government was the only component that was training health personnel.
Yes.
Health personnel, yes. And with time, I think we have about 4 public universities. But now the public universities are supported by private universities in terms of churning out medical doctors. And of course, we've a number of colleges that are training nurses and also training clinical officers and environmental health personnel. Now, yes, we've made strides in terms of increasing the base in terms of training. We have individuals that graduate from these facilities. If you look at medical doctors, I think we should have about maybe 200 annually that are coming out.
Okay.
But how do you deploy these individuals? Most of the deployment will be in the urban areas. Then a fraction will go into the rural areas. But when they get into the rural areas, are we able to retain them? Retention is a bit difficult. They may be there for a few months, and then they may have challenges in terms of operating there. And it's not just about their emoluments in terms of pay. That is a challenge, but also other conditions of service. And that's what makes most of the individuals not stay long in the rural areas. Then when we come to an urban setting also, we have both what I may term as internal brain drain and external brain drain.
Okay.
While government is training health personnel, doctors, nurses, the public institutions are not able to retain them because they end up getting into either NGOs locally or indeed they go abroad to look at greener pastures. And as I mentioned earlier on, the areas have to do with conditions of service and personal emoluments. So if training has been strengthened, then retention has been a challenge, then it's very difficult for us to have access to health in rural areas. Then the other thing maybe we should look at is the commodities. I know the medical stores is trying to decentralize so that they have depots for distribution of commodities at provincial level and indeed at district level. In the past, it was a challenge to deliver the commodities because distribution was centralized. So for us to afford to give a minimum package in terms of access to health, we need, one, to make sure that we have the right health personnel on the ground, and then two, we need functional facilities in terms of pharmacy delivery, laboratory delivery, and also the commodities, the medicines, the laboratory reagents should be in place. An individual should not go to their facility and then they are given a prescription, or indeed they are given a lab form for them to go and access services elsewhere and then get back to the facility. And when you look at a rural setting, where do they go to access those services? It means that they will have to move kilometers, 200, 300 kilometers to the level 1 facility. So government per se has a lot to do in terms of strengthening the structures at a local level in the rural areas. When I talk about external brain drain, I'm talking of trained health personnel, medical doctors, nurses, and other paramedics getting employed outside Zambia. And in the recent past, you are aware that Swaziland, Zimbabwe, South Africa used to get most of our trained health resource. And indeed, most of our doctors went to the UK, and some would practice in Europe and the States. So that's an external brain drain. You train health personnel, and then the beneficiaries are actually either the neighboring countries or indeed the developed world.
Yes.
Then when you talk about internal brain drain, you are aware that with the coming of interventions for HIV, a lot of NGOs came up, which are funded by external agencies in terms of delivery, preventive and treatment services for HIV. So most of the practicing doctors and nurses have moved from public institutions into the private, working with NGOs in the area of mostly prevention. So this is a resource that is supposed to be in the clinical area, but has been diverted to, most of the times, just carry out public health interventions. So that is the internal component. But it's not about just NGOs, but we're also talking about the private health institutions that have come on board to support government in health delivery. They are also taking a number of our personnel. But you know the cost of accessing a medical doctor in a private institution is not that cheap.
Yes.
It's a dual problem.
Okay.
One, it's about the financial compensation. Then two, the environment in which they have to work.
Okay.
Those are what you may term as hard operation areas. And for one to work in such an environment, the situation should be such that at that level, they are given at least the minimal amenities that they have to access. But if they have to be in that environment and they have to move kilometers to go and access social amenities, to go and access maybe their groceries and so on, it becomes a challenge. They have a physical challenge and a psychological challenge.
Okay.
And most of our trained personnel do not last in that kind of theater where they have to go and face all those challenges. Therefore, in the recent past, I think the government has looked at introducing a hardship allowance so as to attract health personnel to go and work in hardship areas.
Okay.
The compensation is one of the challenges. Then the second challenge is the job satisfaction. Job satisfaction, I'm talking of such a scenario where if I turn around, I'll find a syringe, and I'll find water for injection, and I'll find the prescribed medicine to give that individual.
Okay.
If I have to improvise, it's sometimes very frustrating.
Okay.
So there's the issue of job satisfaction because commodities are not to the expected level in most of the rural settings.
Yes.
Then there's the issue of what I talked about as a psychological and physical stress because of the environment under which they operate. I know you've been to rural Zambia and you know that access to services is quite a challenge. And look at this individual who has gone through training and after training, they are looking forward to, one, having a job where they can develop themselves academically, and develop themselves at a socio-economic level. And then you have that individual placed in that environment where they can't access some of the facilities that require them to develop. So that's the reason that rural areas have a challenge in terms of having the required health personnel so that the rural dwellers can have the access that they require in terms of health services. The facility can be there, the commodities can be there, but that requires a human being to deliver that service.
Yes.
The health sector has been affected, of course, by, you look at the morbidity and the mortality in the country. I think those are some of the measures of the impact of the services that are being provided. I'll give you an example. You have someone who's in a setting where there's no maybe level 2 or level 3 hospital. They are referred to a level 2 or level 3 hospital. Let's talk about the level 3 hospital. They're supposed to come to Lusaka. And then they're given an appointment that they'll be seen in 3 months' time. But this is an individual who has a chronic ailment. What is expected of this individual? They may not reach the 3 months.
The 3 months.
Down the line, they may be the late. 2, what do you expect of the condition? They will deteriorate.
Yes.
So, because of lack of access at that level, it does contribute to the levels of morbidity, chronic illness, individual requiring rehabilitation, and you know that we have many more rehabilitation centers. And of course, there are some deaths which could have been avoided. And people die because they didn't have access to the right facility. That's a challenge. Look at cancer patients. We have only one facility, specialized hospital, which is the Cancer Disease Hospital. Meaning that if you are in Sangu village somewhere in Luapula, you have to be referred to Lusaka. So if some of these services can be decentralized, of course I know previously there were mobile hospitals which could carry different components. But again, when you look at certain conditions, they may not have access to what is required in terms of treatment or diagnosis at the level of a mobile hospital. So really the challenge of having a holistic package in terms of health delivery does affect the health of the nation. Brethren, one, I should categorically indicate that retaining health personnel is not just about monetary terms.
Okay.
It should be a holistic approach.
Okay.
While we look at their personal emoluments, which should be competitive, when I mean, or I talk about competitive, I'm talking about a salary structure which, if they look out in Botswana, they look at South Africa, they look at Swaziland, they are getting no differential for them to make a move.
Okay.
Then 2, there should be academic progression. In medicine, the developments are quite fast. There's no field where occurrences in terms of literature change at a very fast rate as compared to medicine. Therefore, there should be access to career development and access to continuous medical education. Then 3, we should look at what other conditions of service go with the pay that one individual gets. What access do they have in terms of health? Is the individual and his family catered for in terms of health insurance? Or do they have to access the same health services where they have a challenge as those that they are looking at? I've had colleagues who have had a family member falling sick, and then they've come back to tell me, if I, a medical personnel, faced these challenges, then what of someone who's not the medical field? So the issue of medical insurance in the package should be looked at critically. Apart from that, the environment where an individual is working should be that when you turn around, you're able to get what you're supposed to use. Job satisfaction. You should not see your client going down because you did not have the equipment to use. You didn't have the medicine to give the patient. I know you know that there have been scenarios where you've seen medical doctors go on strike.
Yes.
Or on a go slow. They've gone on a go slow not because they want a high pay, because they are saying, we do not have what we're supposed to use. That has happened, I think, in this country, and it has happened in neighboring Zimbabwe and the other countries. So it's a holistic, comprehensive package that would retain health personnel. As long as we pretend to be looking after health personnel, then they will also pretend to be around. The minute a carrot is dangled, they are gone. It's not everyone who is patriotic to sacrifice. They also look at themselves as individuals. What will I be in 5, 10 years' time? Will I retire and have a home? Or I will choose to work throughout my life because my conditions of service are such that I cannot save for me to have a place where to rest when my working life is over. So that is a challenge with retention. And it's not just with medical doctors. It cuts across nurses, clinical officers, environmental health personnel. So we need to do something as a country. In the past, it was a challenge.
Okay.
HIV brought a strain on health personnel because in the 80s and part of the 90s and early 2000s, you are aware that antiretroviral therapy just came on board around the triple combination around 1997, somewhere there. And then you are aware that there was cost sharing until about 2004, when our government came in to give antiretroviral therapy at no cost.
Okay.
Yeah. So the time that there was only monotherapy from about 1985, we only had the AZT. AZT would help, but most of the cases would end up in a full-blown condition. So meaning that the hospitals became congested. And then if you look at the doctor-patient ratio, nurse-patient ratio, this made the ratio even very high. Because with the little human resource that we had, which would cope with the normal disease burden that we had, we now had an increased burden. Then, apart from a strain on the human resource, there's also a strain on the resources for the health facilities. we are lucky the donor community came in to pump in some cash so as to support government efforts. I'm not saying that government was not doing the best that they could. Government has done the best that they can, but there are other competing national agendas that finances are supposed to go in. So there was a drain on the resources, and then we look at that individual who's supposed to be part of the workforce. Most of the time, because there are no medicines, prescribed medicines for the control of HIV, it meant that individuals were in and out of hospital. So the manpower that is supposed to drive the economy was affected, meaning that that had also an impact on the economy of the country. But from about 2004 going upwards, when we had high reactive antiretroviral therapy, the scenario started changing. Now we have the Lazarus syndrome. Those who were supposed to die are now living normal lives.
Okay.
And the impact of HIV has actually been reversed because of having life-saving medications that are prolonging life. But in terms of what the government has to contribute, the more you have health people around, it means that even the investment on health should be increased. So the fact that more people are living has not lessened how much government is supposed to spend on health services. What has been reduced is what government was spending on having individuals spending time in the hospital, being nursed. So there was a strain on human resource, strain on materials. These days, you get your package sometimes for 6 months. You only reappear after 6 months,
Okay.
which is much easier. And of course, if you look at those parameters, you find that there's been at least relief in terms of financial burden on the facilities and indeed government.
Okay.
What I would say is that the experience that we had with HIV has actually taught us a lot in terms of a response to epidemics, or indeed a response to a pandemic like HIV and indeed SARS-CoV-2. Now, the difference with HIV and SARS-CoV-2 is that HIV did not stop us from going for work. HIV did not stop us from coming close to a relative or a colleague. That is the difference with SARS-CoV-2. The fact that SARS-CoV-2 stops us from going to work, interacting with other individuals, it means that that component which requires a human touch in terms of delivery of services in the country is cut off.
Okay.
If you look at the education sector, we have courses or programs that require hands-on, like medicine. You cannot learn medicine on the virtual platform. It's almost impossible. Engineering, you can't learn engineering on the virtual platform. You need to be hands-on. So if you look at that component, you see that really SARS-CoV-2 has had a negative impact in terms of delivery in the country as compared to the impact that HIV had. And mind you, for SARS-CoV-2, it's just a short period. We were, and we've been with HIV for a longer period. Now, what has SARS-CoV-2 or COVID-19 taught us? It has at least taught us to maintain basic standards of hygiene. I know that before COVID, the time that your colleagues come to your home and so on, you'll be hugging everywhere and so on. We didn't know that hugging could be a risk for transmission of airborne diseases. Individuals would wash hands, but not everyone would wash their hands. Sometimes I would take some subjective research, not objective of course, where I try to monitor colleagues. We are having a drink and so on, how many go in private space and then they come back and they wash their hands. Very few. But now it's a norm. Some are even becoming a bit neurotic. Just touch a surface, they will rush to go and wash their hands. Or they will get alcohol-based media and clean up their hands. So it has taught us hygiene, but it has had a very negative impact on us, especially in economies like ours, which are not resilient to shock. If the economy is affected, it means that health care delivery is equally affected. Because most of healthcare delivery is financed by government.
Okay, yes.
And if government is constrained in terms of resource, either the cash itself or indeed the commodities to provide health facilities, then it means that the delivery of healthcare services will be adversely affected. So effect on the economy has a direct effect on healthcare delivery. Yes, the personnel will be there, but do we have the commodities to make the facilities run? They are not there. So that's a challenge. And then your human resource, some of them have been told to stay home because you cannot overcrowd a facility. So basically, SARS-CoV-2 has had, it's a double-edged sword. In whichever aspect of life you look at it, the economy, healthcare delivery, it has had a very big impact. And like I mentioned earlier on, some economies are not resilient to shocks.